Just wait. Yes, please wait. Sorry for the delay. Yeah, तुरंत होगा. So welcome all for the preferred practice pattern seminar of Jharkhand Ophthalmological Society, as well as Cornea Symposium of Jharkhand Ophthalmological Society. We have very eminent national speakers today, as well as entire Jharkhand's cornea specialists have joined. The postgraduate students, they have also joined across our state from all the medical colleges and DNB institutions. So over to Jharkhand Academic Research Committee Chairman, Professor Sunil Kumar, who is the head of Rio Rims Ranchi. He is going to introduce our five national speakers, Dr. Vardhaman Kankaria, Dr. Nivedita Narayan, Dr. Soumya Basant, Dr. Divya Manohar, and Dr. Prafulla Maharana. So over to Dr. Sunil Kumar. Please share the slides.
Thank you, ma'am. So
Please share.
on behalf of JHOS, I welcome everyone on this master class of cornea and preferred practice pattern. So we have the five national speakers in this program. So first, I will introduce Dr. Bardhaman Kankaria. Can I have the slide, please?
Yes, please wait.
So
Yes.
yeah, so Dr. Bardhaman Kankaria needs no introduction. She is ever young looking, very dynamic and a smart guy. And is the ex-chairman Scientific Committee, Maharashtra Ophthalmological Society, member Scientific Committee, AIOS, International Council members, member Scientific Committee of the International Keratoconus Society, chairman of the Asian Eye Hospital, Pune, former honorary secretary, MOS, is the 55 international publications, more than 1300 citations. That's a great number. 14 Best Paper Award, 32 Life Surgery, 7 prestigious Oration Awards, and gold medals of more than 45,000 refractive surgery. And is the only Indian LASIK surgeon who is trained by none other than the Professor Pali Karis, who is the father of the LASIK. He is the IGO section editor of the refractive surgery. He was news section editor of the refractive surgery. He is the alumni of the Sankar Netralaya Chennai, University of the Great Greece, and Bascom Palmer Eye Institute, USA. So welcome Dr. Bardhaman Kankaria with
Next.
JHOS this CME. So next I will introduce, next slide please. Yeah. So I welcome Dr. Niveta Narayanan. She is the senior consultant with a special focus on cataract surgery, including femtocataract, and the lamellar corneal surgery, including DSEC, DALK, and LK, and the refractive surgery, especially SMILE. She is the deputy director of accreditation, safety, and quality assurance of the hospital. She is the FECO fellowship from the Medical Research Foundation, Chennai. She received the advanced training in cornea and transitioned to the cornea refractive services in 2006. She has attended numerous national and international conferences, presented papers, and conducted instruction courses in wet labs, published extensively in peer-reviewed national and international journals, and she is passionate about the teaching and regularly trains students and fellows in the above area. So welcome Dr. Niveta Narayanan. So next slide please. So next speaker we have is the Dr. Soumya. She is the fellow in cornea and external eye disease from the RIO, Bangalore Medical College, and she is currently working at Jamindar Microsurgical Eye Center as a cornea consultant. And she is a yoga enthusiast and keen interest in the agriculture. So this is the extracurricular activity. So welcome, Dr. Soumya. So next we have
Next, sir.
with us we have Dr. Divya Manohar. So she has the clinical research interest in the corneal diseases like dry, Sjogren syndrome, MGD, keratoconus, refractive surgery, phakic IOL, keratoprosthesis,
नहीं glasses
lamellar
glasses
infiltrating keratoplasty, SLDT, and femtosecond cataract surgery and eye banking. She had done the MicroMaster in Clinical Epidemiology from the University of Michigan, Fellowship in Cornea and Refractive Surgery from Urban Madurai, MS from the Urban Madurai, and MBBS from the Chennai. She has a lot of surgical skills, including 2000 plus refractive surgeries, DALK, DSEC, DMEC, optical and therapeutic penetrating keratoplasty, FACO, MSAS, iris claw, SFIOL, toric, and multifocal IOL, corneal tattooing, patch graft, CXL, pterygium glue. And also in the field of the keratoprosthesis, OSSN management, and combined anti-segment surgery. So welcome Dr. Divya Manohar to this JOS CME. So this is all about the introduction of the our guest speakers. So over to Dr. Bharti Sharma, I think for the introduction of the local
Yeah.
speakers.
So thank you, Dr. Sunil. So can I have the next slide, please? So I have the honor of introducing all the cornea specialists from Jharkhand.
Hmm.
So if I can have the slide.
Dr. Bharti, we have to introduce Dr. Prafulla Marana also.
Okay.
Dr. Sunil forgot to introduce Dr. Prafulla
Acha.
Marana.
Okay.
Dr. Prafulla Marana, we are sharing his slide.
Yes,
He
ma'am.
will join after some
Acha.
time. He is in DOS urgent meeting.
I think when he will join, then we can introduce him.
Host,
Ma'am, when he will join Dr. Parpula, then we will introduce.
okay. The host has done something. What has happened to the host? Okay, we are doing.
Yeah. Ma'am, so
So,
the slides of the local speakers.
yes.
Control slides of the local speakers.
So, Dr. Bharti, please
Yes, ma'am.
introduce the local speakers. They are all prominent, eminent cornea surgeons from Jharkhand.
Yes, ma'am. So can I have the slide?
We are we have we are showing it.
So I think I
No,
will start with nobody else than Professor Dr. Sunil Kumar, who was introducing all the national speakers. So by the time they are sharing the slide, Professor
No, I
Dr.
have
Sunil
we have
Kumar,
shared.
no,
Is
no,
it
it is
not
not
visible?
it
not
is not
visible. Ma'am.
visible.
Its prior slide is visible.
Okay, okay, okay. Just wait, please.
Yeah, yeah. Now it's
Yes.
come. Do the slideshow. Yeah,
Yeah, please
yeah,
start.
yeah.
Yeah. So, Dr. Sunil Kumar is professor and head of the department, Rio Rims, Ranchi. And he's also the medical director of Government Eye Bank, and he's the chief cornea services of RIMS, Ranchi. He has done his MS ophthalmology and senior residency from our prestigious PGI Chandigarh. And he has published more than 50 papers in national and international index journals. He has a lot of awards which go up to him. Best paper award in 2005, and then poster award in 2007, winner of AIOS quiz 2014, Dr. B.N. Gupta Endowment Ecoin Award 2022, East Zone Ophthalmological Society State Award for Jharkhand in 2023, and late Dr. R. Singh Memorial Oration Award in Varanasi 2024. He is also got Distinguished Ophthalmic Teachers of India Award in 2024. Professor Sudhir Kumar Endowment Oration Bihar Chapter 2025, and he's also the Associate Editor of International Journal of Medical Ophthalmology. Welcome, Dr. Sunil. I think we all
Thank
will
you.
be enlightened to hear and from the experience
Thank you,
that
ma'am.
you have. And RIMS is one of the largest hospitals here in Jharkhand, which caters to most of the patients.
Thank you,
Can I
ma'am.
have the next slide, please?
Yes, we are doing it. Please wait. So next is our uh, another speaker, Dr. Bharti Sharma, who is introducing all of you. She is the head consultant and HOD, Tata Main Hospital, Jamshedpur. She is the cornea. She has done her cornea and cataract fellowship from Shankar Nitralaya, Chennai. She is the gold medalist Shankar Nitralaya, Chennai. She is the former consultant cornea and refractive services Shankar Nitralaya, Chennai. She is the former senior consultant Apollo Bramwell Hospital, Mauritius. Presently head consultant and HOD Tata Main Hospital, Jamshedpur.
Thank you,
Next
ma'am.
slide.
Yeah.
So we are honored.
Thank you, ma'am. Thank you so much. So we have with us Professor Dr. Seema Kumari, and I welcome you, Dr. Seema. She's a very young and budding associate professor from Department of Ophthalmology, MGM Hospital and Medical College, Jamshedpur itself. She is the former head of the department also, and she has worked as a nodal head of MGM Eye Bank. She has done her MS ophthalmology from Darbhanga, Bihar, and senior residency under Dr. Sunil himself. She was telling me in the morning from RIMS Ranchi. She has fellowship in cornea and refractive surgery from Chitrakoot, again a very prestigious hospital in our country. And she's also fellow of IMA College of General Practitioners. She has published more than 40 papers in national and international journals, and she is a very active member in various research committees. She is winner of very prestigious Dr. Dukhan Ram Gold Medal Award for Best Paper on Keratoplasty. And in 2010, she has presented many papers in AIOS, Jharkhand Ophthalmological Society, Bombay Ophthalmological Society, and MP Ophthalmological Society. We welcome you, Dr. Seema. And I know that you are a very young and you are always very keen to teach our junior doctors. So I am very sure all our PGs will learn a lot from you. Thank you so much. Can I have the next slide,
Yes,
please?
yes, 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 yes. Doing it. नहीं दिख रहा.
I think it should be Dr. Nidhi.
Yes.
So, Dr.
Yeah.
Nidhi is, I will start slowly. Can you please display the slide?
Slide speaker.
Dr. Nidhi,
Just wait.
yeah.
Is it visible?
No, ma'am.
Is it visible?
Yes, ma'am. Yes. So Dr. Nidhi Gatkar Kashyap is again a very young budding cornea surgeon. She is from our very own Kashyap Memorial Eye Hospital, Ranchi. The slide is not, yeah. So she is MS gold medal in MS, and she has DNB, FRCS Glasgow, Edinburgh. You can name all the degrees that she has, FICO, and she also has ICO. She has a fellowship in cornea and external diseases. She is the chief consultant, and she also heads the eye bank, cornea and eye bank services from Kashyap Memorial Eye Hospital in Ranchi. Welcome, Dr. Nidhi.
Hello, ma'am. Good
Yeah,
evening, everyone.
yeah. So, next slide.
Yes. Is it visible, Dr. Pooja Kumari?
No, ma'am.
No, no.
Just wait. Is it visible?
No, no,
Not
ma'am.
yet.
Okay, wait.
Yeah, now
Yes.
it's visible. It's
So,
visible now.
Okay.
yes. So Dr. Pooja Kumari, again, our own from Jamshedpur. I'm very proud of the fact that she is here. Dr. Pooja Kumari is a senior consultant, Department of Ophthalmology in Tata Motors, sorry, Jamshedpur. She has done her MBBS from Jipmer Pondicherry, where she has had a gold medal, MS again from there, and she also has DNB and FICO. She's ex-senior resident from Dr. RP Center, New Delhi, and she has done senior residency in cornea, cataract, and refractive surgery and ocular oncology. She has received Best Senior Resident Award in year 2019-20 at AIMS Delhi. She has published more than 20 publications in national and international index journals and also has few chapters to her credit in corneal infections and inflammations. She is currently working as a senior consultant and acting HOD at Tata Motor Hospitals in Jamshedpur. And she was also formerly associated with Kashyap Hospital in Ranchi. So, welcome, Dr. Pooja. Are you there? Yes.
Thank you, ma'am.
Yeah, thanks. So can we have the next slide, please?
Yes, yes. Let's just wait for 1 minute. We have two more speakers, Dr. Neha Gandhi Madan and Dr. Poonam Rawat. So we
So
have,
both are again from Jamshedpur. So we have lot of
yes,
cornea people in Jamshedpur.
correct. But iBank is most developed in Ranchi.
Yes, 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 ma'am. There is, but I think we are coming up with one eye bank here in
Yes, yes,
MGM
yes.
Hospital also,
Yeah.
and that will also help us. So I think it should be Dr. Neha Gandhi Madan and Dr.
Yes, Neha Gandhi Madan and
Dr. Poonam Rawat.
you have the slides of Dr. Neha Gandhi Madan in your mobile. You can read that.
Yes, so I can speak about Dr. Neha.
Yes,
Are you there,
yes,
Dr.
yes,
Neha?
she's there. She's
Yes, yes.
there.
So
Yeah.
Dr. Neha is welcome. Dr. Neha Gandhi Madan has her diploma in ophthalmology from D.Y. Patil Medical College and Hospital, Navi Mumbai. She has secondary DNB done from Shankarai Hospital, Coimbatore, and after that she has gone to do a long-term fellowship in cornea and anterior segment services from LB Prasad, Hyderabad. She has cleared her FI, CO, and FICO corneal exam, and currently she is working as consultant cornea specialist in Jamshedpur at Jamshedpur Eye Hospital. Welcome, Dr. Neha.
Thank you, ma'am. Thank you.
Yeah,
Is the
great.
slide visible? Is the slide visible of Neha Gandhi
No,
Madan?
no, ma'am.
Okay.
So maybe it will come now. Yes, yes. It
Okay.
is.
So now we welcome Neha. Then next slide, please, for the Poonam Rawat.
Dr. Poonam Rawat. Yes. So Dr. Poonam Rawat, welcome. So Dr. Poonam has done her MBBS from Bombay, Mumbai, and DNB of TAL from Noida. She has a fellowship in cornea and anterior segment from Arvind Eye Hospital, Madurai. And she's associate ophthalmologist and cornea specialist in Jamshedpur Eye Hospital. And she is very dynamic and does lot of cataracts and corneal surgeries. We welcome you, Dr. Poonam. Are you there?
Yes, ma'am. Thank you, ma'am.
Great. So now, ma'am, we can start with the webinar. Thank you so much.
Yeah, now over to Dr. Vardhaman Kankaria for his talk on keratoconus.
Thank you, ma'am. Yes. Yes. First of all, thank you to Dr. Bharti Kashyap, ma'am. I've had privilege of knowing ma'am and sir for several decades now. They are a great inspiration. And thank you, ma'am, for the kind invitation. I would like to also thank the other office bearers of the Jharkhand Ophthalmic Society, Professor Sunil Kumar, sir, and Dr. Bharti Sharma, ma'am. Friends, I'm going to talk to you about, as I understand, this is going to be for postgraduates. I hope my slides are visible.
Yes, yes.
Okay, great. Yeah. So as I've been told that this is going to be for postgraduates, this is a topic that you will probably not get in your ophthalmic textbooks. So I will try and make it simple. We have all heard of cross-linking that is done for keratoconus, but I'm going to talk to you about something which is more advanced, something in which give your patients more functional vision that you can actually get only through cross-linking. And this is the topic of my today's talk. I don't have any financial disclosures. So friends, we all know that collagen cross-linking is well-established treatment, and this is being done for more than 2 decades now, where UVA light along with the riboflavin creates production of oxygen radicals, free radicals in the intrastromal corneal filaments, and then it causes induction of collagen cross-linkage. This collagen cross-linkage is known to decrease cornea's deformability and is known to halt keratoconus progression. This was first time that such an entity was developed by Professor Theo Zeiler and his team, and in which it was now then possible to stabilize keratoconus. Now let us look at one very interesting case. So this is one of our earliest cases of cross-linking or keratoconus back in 2007. So Swati was actually a young girl who came with progressive keratoconus with a low uncorrected visual acuity and a relatively low best corrected visual acuity of 6/18 or 20/60. She had a relatively thicker corneas of for keratoconus about 490 micron, and she was contact lens intolerant. Because she was having progressive keratoconus, of course, the best approach was doing a Dresden protocol. That is a traditional protocol which was started in those times, which was a long form of cross-linking. And as you can see on the right side, on the lower topography, you can see the pre-operative, and on the upper topography, you can see the post-operative scan. And the one on the left side is the differential map. You can see very well that not only that this patient achieved a topographic stabilization, but she actually showed some more flattening and improvement in topography as well. So as doctors, we were very happy, but Swati was not yet happy. And the reason was she was still having poor best corrected visual acuity because she was still contact lens intolerant. Then we went on to realize that many of post-CXL patients do not achieve good functional vision, especially when they cannot tolerate contact lenses. And that is because of unaddressed component of remnant irregular astigmatism. This irregular astigmatism, as we all know, is the hallmark of keratoconus. So the ideal treatment of current times should have not only stabilization of keratoconus with cross-linking, but also visual rehabilitation of these patients by doing something what has been nomenclated as the CXL Plus platform. CXL Plus is a brainchild of one of my mentors of keratoconus. His name is Professor George Kimionis. So we will go through some of this CXL Plus approaches. And to begin with, we are going to discuss about CXL and then following up on the second sitting with topography guided PRK. Konolopoulos et al. From Greece actually devised a two-stage procedure in which he first performed a cross-linking to stabilize keratoconus, and about 1 year after cross-linking, he performed a topography-guided PRK. So my friends who are postgraduates, just to tell you what is a topography-guided PRK. Topography-guided PRK is the one in which you feed the topography of the patient to the examiner, and the examiner tries to smoothen the topography, regularize the topography. So in this case, the attempt was made to improve the functional vision. So although the functional vision improved in these patients, but it had two nagging problems. Number one was it was removing already a cross-linked cornea, and the haze was also seen more than the routine PRK. Therefore, Kimionis et al. From our group and Konolopoulos also at the same time devised and published in 2009 a protocol which is now known as Athens protocol. What is Athens protocol? Athens protocol is when you're actually doing a partial topography guided PRK, and immediately in the same sitting, you are doing a cross-linking treatment so as to give regularization of topography on one side and stabilization of keratoconus on the other side. So this combination was what is called as the Athens protocol. So let's look at one example. So this is a 26-year-old patient who comes with best corrected visual acuity of 6/12 with a keratoconic patients with reasonable thickness of 467 micron. In this case, when we have done a topography guided PRK, as you can see in this case, this feeds the topography to the examination, and you are actually regularizing the topography in this way. So with this approach, it is important for you to know is that the correction is only to regularize the topography. It is not to actually give the refractive correction to these patients, or therefore you are not supposed to attempt full correction. You should not ablate more than 40 microns or at max 50 microns by keeping a smaller optical zone. So in this patient from 6/12 vision or 20/40, the patient actually went on to have 20/20 vision by a significant improvement in topography, as you can see in this patient as well. Then we realized that if this is better, can this be proven in a contralateral study? Therefore, we went on to perform a contralateral long-term evaluation in one eye by doing only cross-linking, and in the other eye by doing Athens protocol in set of 31 patients. So in this patient, this was published back in 2016, almost a decade back in a prestigious journal of ophthalmology, where we showcased that when you have Athens protocol, there is more gain of uncorrected visual gain of 30 letters versus 8 letters only on the cross-linking. The best corrected visual acuity improved in Athens protocol by 8 letters on logMAR as against only 4.7 letters with the cross-linking. And the most important thing, none of the patient had lost any lines of Snellen chart. That shows a great amount of safety. What about the long-term success? This is a 10-year outcome study which was published on Athens protocol by Konolopoulos, which has actually shown a great amount of safety and efficacy over a very long time, which is about a decade. Now, friends, there are a lot of patients who may have moderate keratoconus but have very thin cornea for doing topography guided PRK. And in these patients, what can we do? So this is a 24-year-old patient who came with now only a 420 micron thickness. So CXL was possible, but topography PRK was not possible in this case. So the question was, we all know that we have to remove epithelium when we are doing cross-linking, but can we use the epithelial removal technique itself to improve the topography of this patient? So we all know from a study by Reinstein et al. That he has shown that epithelium in keratoconus is not regular. It is actually of donut shape. That means it is thinner at the apex of the cone. It becomes thicker as we go along in the periphery. By using the same hypothesis, you can see that in this patient, epithelium is thinner. So if you are actually using a PTK of 50 microns, then you are actually topping off not only the epithelium, but you are also smoothing a bit of underlying stroma where the topography is going to be steep. Therefore, in these patients, you can actually regularize cornea by just doing a PTK. So this smoothing effect of PTK was devised, and when it was combined with cross-linking, this was called as Cretan protocol. Cretan protocol was first devised by our team led by Professor George Quinones, which we published back in 2013. You can see in this case, this is the pre-operative and the post-operative topography showing an excellent smoothing of topography. So then we went on to do one more long-term study in which we did Cretan protocol in one eye and we just did a Dresden or a standard protocol in the other eye in set of 31 eyes. And we did see that there was a statistically as well as clinically significant improvement in patients who had PTK CXL versus only regular CXL with manual epithelial debridement. We published these studies in variety of international journals, and now we have recently also published a long-term result of this Cretan protocol in set of 23 eyes over a duration of follow-up of 5 years. Now let's come to the 3-year third case scenario. So this is a case scenario which is common in patients who have moderate or severe keratoconus. You can see there is a very high asymmetric irregular astigmatism in this patient and very high amount of astigmatism going to almost 15 diopters. So if you have a 15 diopter astigmatism, of course, there is no way that the topographic guided PRK or a PTK can help this patient. Therefore, the best approach is what is called as the intacs. Intacs are intrastromal ring segments. So they can now also be done with biogenic implants, which I'm sure that Dr. NVN is going to speak now very soon with the help of CARES. This has the buttress effect in the periphery and smoothens and flattens the cornea in the center. Therefore, it is known to reduce irregular astigmatism to a large scale, especially in this kind of keratoconus. And then this can be done with the same sitting or after 6 months with cross-linking to stabilize keratoconus. So in this particular patient, you can see this is the pre-op on the lower side, post-op on the upper side. The astigmatism has reduced drastically from 15 diopters to very minimal astigmatism, and the vision has drastically improved in this patient from best corrected 2040 to uncorrected 2070. Now, this last case scenario is a case in which you may have a lot of patients where there are patients who have mild keratoconus with very good best corrected visual acuity still available, but has very high myopia. So when you have ensured that the patient is actually stable by doing cross-linking or stable on its own, at least for a duration of a year, you can actually take advantage of the current generation of toric phakic lens implants such as toric ICLs. We have a large series of such patients. We have recently presented about 700 plus patients in our APO last year by one of our fellows, and it is going to be published soon in IGO. So you can see in this patient after the ICL implant, the best corrected visual acuity improved to even 20/30 with very minimal astigmatism and uncorrected to almost 20/40. So friends, this is an algorithm that all of you can remember is that whenever you have a patient who has keratoconus, of course, a patient who has deep scars, very thin corneas for cross-linking, very low visual acuity, cannot be fitted with cross-linking, you must plan to do a form of transplant, either DALK or a PK, depending on the case. But yes, if the patient is better, has mild to moderate keratoconus, is showing no progression, then just tell them to avoid eye rubbing, follow up with serial photographies. But if the patient does show progression on topographies and has acceptable thickness, you can perform one of the CXL plus procedures, either CXL with topoguided PRK, PTK, intacs, or phakic lens implants, and thus give these patients a completely new quality of vision, giving them a complete treatment, not only stabilization, but also improving on their functional vision with this adjuvant treatments. So I'm going to leave you with the quote of well-known Mr. Thomas Edison, the world-renowned scientist, that there is always better way to do it and we have to find it. Thank you very much for your kind attention. Thank you.
Thank you very much for enlightening us. And we are also doing regularly this Athens protocol, Cretan protocol, and trek also. So, what is your experience on trek? Means a trek is actually a Narana Nitrale initiative.
Right.
So, have you compared this Cretan with trek? There is a very little difference. We do PTK in Cretan, and in trek we just remove 20 micron stroma also over the cone. So do you do trek? And if yes, have you done any comparative evaluation, comparison of trek and PTK?
Yes, ma'am. Thank you, ma'am. I think it is a nice question. And as you have said, they are very close procedures to each other because
Yes,
also in Kritan, you are topping of the epithelium and a bit of extra stroma at the apex of the cone. And because trick can be done only with the Schwind examer lasers, where the Kritan protocol can be done by
any.
any examer laser. So in Schwind, as ma'am has said, you can decenter the focus and you can go locally at the apex of the cone and you can do a PTK. So we can say that trick is almost doing Cretan protocol localized. So it's like doing localized Cretan protocol. And I
Actually,
believe,
what you said now, there's actually the cornea is thin at the center. So
yes,
when you are ablating in
yes,
even with cretan at the center, it is taking some of the stroma.
yes. So it automatically smoothens the
It is
stroma.
like
The
track.
same thing like trek. Yeah, correct. Very
Correct.
true. So it is like a trek is a kind of offshoot of Cretan protocol. I believe both of them work very well with the amount,
Yes,
with the
yes.
kind of examiner one has at disposal. One can choose either Cretan or the trek.
But previously we were doing cretan, but since the time we have got shrined, we are
Yeah,
regularly doing trek. The
right.
trek results are very good, and after the scleral contact lens, the vision improves a lot.
Yes, ma'am. Absolutely. Yes. Yes.
So thank you so much,
Thank you. Thank you, ma'am.
Vardhaman.
Thank
And
you.
if you stay with us for some longer time, you can be the good discussant for other national speakers.
Yeah, thank you, ma'am. Thank you, ma'am. I think
So the next speaker
thank
is Dr. Nivedita Narayana. So over to Dr. Nivedita. She's going to talk on her preferred technique on cares in keratoconus.
My slides are visible.
Yes. Yes, Vardhaman.
Yeah, thank you, ma'am.
Okay, it's seen, right? Yeah. Am I audible? Okay. So my preferred technique of cares in keratoconus. Cares is corneal allergenic intrastromal ring segments. So where we use a donor cornea in the strip form to smoothen the cone in keratoconus patients, select patients. So whom do I offer? It is a progressive keratoconus, asymmetric cone, decentered, paracentral, clear cornea, thinnest packing not less than 350 microns, and those who are intolerant to contact lenses. So there is a specific indication for cares. Exclusion criteria will be all inflammatory, lactating, pregnancy patients. Central cone, we don't do. Any thin cornea less than 350 microns, we don't touch. And other ocular and systemic comorbidities. So with this kind of cares, we also have the option of customization. So factors which will help us in customization is based on the severity, location of the cone, the zone, the steep axis where it is, and the pattern of astigmatism. Customization can be done by either single edge taper, double edge taper, or central. So when you customize, it is very personal to that particular individual topography of the patient. Instrumentation required are very simple. There is no big thing except for the double punch, and the customizer number 2 is a very important thing for customization and perfect positioning. 3 is that arc spatula like thing which can help us in pushing, and we also mark so that you need a marker. So initial cases are used to do the Bauman's marking. It is very important thing because it helps in identifying the orientation of the graft while customization as well as while it is being pushed into the channel. But we have to be careful because it could be endothelial toxic. Over a period of time, you will know how these grafts behave, and you don't need the Bowman's marking in the later cases. So let us see how I personally do it. So I take the 6 millimeter ring and see meridionally what is the astigmatism. So from this diagram, we know between A to B, the meridional astigmatism is high. At A, it is 14, at B is 10. So, and beyond that also there is 3 at C and 3 at D and 6 at C. So that area is what needs changing. You have to do the changing in the steep axis. But between A to B, we need the maximum thickness. And beyond that, we can taper. So this is actually customization. So when you create a channel on the host cornea, you do a channel in such a way that it straddles the area of the 6 millimeter ring. And then you create the graft in this fashion and push it into the channel with the Bowman side facing centripetally for the thing. So now these are the parameters of the intrastromal channels that I use. And I actually slightly enlarge the channel so that the pushing will be easier. Not more than 50% depth of the stroma in that 6 millimeter ring I do. Very important is when we use a normal examer, centration is key. Just like how you do the toric lens, you have to mark the 6 and 9 o'clock, and then the central coaxial sighted clear corneal light also should be marked so that you can position the cone exactly on that. Now I normally do my DMEC. I remove the graft. I put it for staining. While I'm doing that, I prepare the Cares graft in the same. So you don't have to go for a special separate. That way you can save the number of corneas that you use. So without removing the outer ring, when you do, the thing comes out very beautifully. The central will be your 6.5 mm graft for a DALC if you want. And the outer 1.5 millimeter ring will be your Cares. Then you can go ahead. First, you'll have to remove. So now we are epithelial side up here. So you have to remove the epithelium with Wexel sponge. Meticulously, slowly, it will start falling apart. And then you use a hockey knife to gently scrape. You have to be careful not to scratch the stroma. It is only a surface polishing maneuver. So once the epithelium is completely removed, in the initial cases, you stain the Bowmans, and later on, you can just use it like that. Sometimes I have tried removing the ring and then punching. When we do that, you can see how the graft is getting distorted. So you don't get a you don't get a nice ring of the graft. It gets punched out in one area and then it is irregular. So I don't recommend that, uneven and uncut. So if it is nicely cut, it should look like this, one ring and one stromal graft. So once that is done, you take the ring and place it on the cup. Cup is a very simple instrument where you can position it, iron it. So then you have to dry it using the Wexel sponge so that it becomes a little pliable. So the first step is to cut it into 2 halves. So I'm just gently drying it. Now I'm cutting it into 2 halves. You can use the normal 15-degree blade. So now we have a tape-like graft. So that can be straightened. Yeah, you can see that, how nicely it is coming. Now you can straighten it. So the top one is the Bowman side. So I'm just flattening it, pushing it to one side all over so that it is not twisted. It is very pliable when it is moist. So now I am bisecting it because we are not going to put the full graft. We are only going to put in that specific segment where we want flattening effect. So I am reducing its size. Sometimes you may need more. This is the best advantage of Cares. You don't need a large size of the ring, just like how we do in tax and other things. This is placed superficially, so it can be of specific size. So once that is cut, you can see how it behaves. The fluffy side is the stromal side and the rigid side is the Bowman side. So you can't mistake this. So you don't actually need a marking. So once that is done, you go on to the customizer. You place it in the exact position at the 6 millimeter ring. So I'm just showing here there, 6 millimeter ring, you position it. And once that is positioned there, then you go ahead and mark. So you mark the clock hours where you want the full thickness, and you also mark the area where you want to trim it. So I have put both the videos simultaneously. You can see it. Yes, once that is done, you take it out and place it on a flat surface. Again, you position it in such a way that the Bowman's is rested flat on one side. Otherwise, it will slip. Your cutting the thing will be difficult. So once this is done, you now go for the final customization. You spread out the graft nicely, and then ends you can trim. So that is the end of the graft that you want. Both sides, you cut one by one. So now from the end to the first mark, you need to taper it. So you can cut the stromal. You have to be mindful to retain the Bowman side in both, because that is the thing which is going to give you the stiffness and the shape and the changing of the cone. So now you have the custom made. So you position it back on the same 6 millimeter ring and let it dry by the time you prepare the channel. 20 minutes is more than enough for it to dry. So now we go on to the patient. We have marked the patient properly, and you can create this kind of a, we have a single entry only, that is good enough. Once you are mastered the technique, single entry is good enough to go ahead with positioning. So this is how you mark the center and the clock hours. So once the channel is created, you will have to open in the platform, which is widely, slightly a widened zone. After that, you can use the Y hook to gently open up the arc, the location where you actually want to position. So by the time all of this is done, the graft is dried. You have to be very careful when you take it, because otherwise it can fly. In this case, it is still in the sterile zone, so I have escaped. So you'll have to gently handle it. You can see how stiff it is. So you can insert it like an intact only. So you don't need anything. Once the channel is open, this beautifully goes in and sits in that place. So you have to mark the clock hours. Suppose in this case, I wanted between 240 to 300. So that area I have opened up. So this will nicely move from the 210 opening towards that. So it will all be nicely pushed in. So now let us look at some cases. This is case of a 23-year-old lady who had plano in the other eye, and this eye had a high astigmatism, and it's a progressive keratoconus. So along with the cross-linking, we decided to do CARES. Post-CARES, her vision is improved, her cylinder is drastically dropped, and she is able to wear glasses of this 20-month of follow-up. When you look at the sagittal curvature, the first one is the post, middle one is the pre, and the third one is the indifferent. So you can see a area of flattening exactly at the location of the graft. If you look at the epithelium, this is the corneal thickness. Corneal thickness also shows that the area of the graft is thicker than the other. So that is the difference. You can see that plus 39 is the area where the graft been inserted. If you look at the epithelial map, you can see centripetal to the area of the graft, there is a thickening. So this is a standard pattern we have noticed in the OCT picture also you can see that inside of the graft, the epithelium is bunching up. So that is some kind of a compensatory mechanism what the epithelium shows in these kind of cases. We'll move on to the next case here. This patient is plano one eye, 15-year-old male. The other eye is -12, -1, 6'9" with his best corrected vision, but he has never worn glasses. We offered him DALK, he refused. So we tried to do cross-linking along with CARES. So you can see how it has been planned and how it has been inserted. And again, if you look at the sagittal curvature map, there is a considerable flattening in the center. And the corneal thickness map shows corresponding thickness. And here the epithelial thickening inside of the graft location is beautifully seen in this picture. Now we move on to the third case. This is a 16-year-old with the right eye -11, -4 at 3/60. So we offered her DALK. Again, the patient refused. So we went ahead and did CARES with cross-linking because the thickness is still 358. In the post-operative period, you can say similar effect, thickening of the stroma. Inside, that arrow mark is showing inside of the thickened stroma, you have the epithelial bunching up like a compensatory mechanism. You can see in the slit view how beautifully the CARES is sitting, and the patient's refractive error is beautifully matching the other eye. So now he doesn't mind wearing glasses in both the eyes. So these kind of cases is really motivating. And that is why I keep doing it, but unpredictability is there. So that is one word of caution. So none of the procedures are without complications. For this patient, we -6 cylinder, I thought it's an ideal case to do. She was doing fine, and then she stopped the steroid and she came back with a rejection-like episode, which eventually settled with topical steroids. Lucky for me and the patient, her vision was not lost. It was well and maintained. Now, next case is 25-year-old lady. She is actually a dentist who refused to wear contact lenses. So she underwent CARES with cross-linking. She came back with an infection. It was an MSSA. We put her on vancomycin. She was responding well. She came back with perforation. We glued it. But the whole area of the graft was perfect, including the channel. Only the place where I had put the suture, she had this problem. So I did not remove the CARES. Lucky for me, it healed very well. And her vision was still maintained. She did not lose it. So she's wearing glasses now. But in this case, the epithelial thickening was not classic like other. So probably the drug toxicity or something changes the way in which the epithelium fashions itself. So that is one lesson we have noted. So in conclusion, CARES is a useful tool meant for based on the meridional astigmatism at the 6 millimeter ring for a specific group of patients where you have a reduction in the refractive error, smoothening of the cone with hyperprolate status is also managed. With our limited group, we are able to reshape and give some benefit to the patient, but the unpredictability is an issue, and we need to follow these patients on a long term. Thank you for this opportunity. It's an honor to be a part of JHOS. And thanks to Bhartika Shib ma'am for calling me for this.
Thank you so much on elaborating on a subject which is not very well practiced even by the cornea surgeons mostly. CARES is a new concept. Not everyone, all the cornea surgeons, they do it. So our next speaker is
Ma'am, a few questions for Nivedita.
Yes.
Ma'am. Can I go ahead? Yeah.
Yes, yes.
Beautiful demonstration, very, very lucid, very clear presentation. So I think anyone who's seen it can go and do it tomorrow. It was that beautiful.
Yes, it was.
Yes. So, ma'am, I have some questions. You were mentioning about doing CXL surgery before doing CARES. So what is the protocol like? And
No, not before. So if, as we already know, say cross-linking will stiffen the cornea.
Yes, yes.
So anything you want to flatten has to be in the normal virgin cornea.
Okay,
So
okay.
you do cross-linking and then you do, you do cares and then you do cross-linking on the same setting.
So what is the time period that you
Same
would
setting,
suggest?
same setting.
Same sitting.
Same
Okay. 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 So does that induce any abrasions or anything of that sort, madam? Even putting a case segment, because you know you're altering the corneal surface. Have you noticed anything, or are the
I
patient?
look at it as two different procedures. The purpose of cares is to flatten the cornea. So that we do based on the prediction that we have calculated pre-op. The purpose of cross-linking for me is to stiffen and arrest the progression of keratoconus. So I don't look at it as changing the power or refractive correction. So when you combine the two, then each one serves its own purpose. And one thing when you combine, you don't go for debriding the epithelium over the site of care. So it has to be a little less. So that's the only hitch.
Okay, okay. But that's where the most steepening is there, right, ma'am? The most of the steepening is there. We are flattening it at that part.
It's not the center of the cone.
Okay.
It's a meridional.
Periphery. Yes.
It's slightly in the periphery. I don't go beyond 6 millimeter because of the unpredictability, and the closer to the center, I don't want to go. So this is the limited case series that we have.
Okay.
And so far, nobody has lost in spite of. So
Thank
case
you.
selection
Thank
is very.
Yeah. Thank you. Thank you so much, ma'am.
Yeah. Okay.
Yeah. So should we switch to the another speaker? Switch over to another speaker. The another speaker is Dr. Soumya Basant. She is going to talk on preferred practice pattern in dry eye. Dr. Soumya Basant?
Yes, am I audible, ma'am?
Yes, yes.
No.
In a very short notice, all the national standards
Yeah.
they have come, and I'm really, really thankful to
Thank
all.
you for having me here, ma'am. Really. Okay. Yeah, we'll start.
Yes.
Is my screen visible?
No.
No. Yeah.